Good morning, good afternoon. Welcome to today's webinar. I can see that many of you are starting to be able to log in, and we are going to get started in just a second. We're just going to take a quick pause to allow all of our attendees to join this webinar, but we do thank you for joining today. All right, well, I see that it's about 2 after, and I know that there are folks still getting logged on, but we're gonna go ahead and get started. My name is Phil Breitenbuscher. I'm an assistant professor at California Baptist University. I'm also a consultant at Wellscreen and a principal at P&B Collaborative Solutions. Today's webinar is entitled Early Detection in Child Welfare, Connecting Families to Quality Treatment Services. This webinar, just so you get an idea of it, we're intending to only go about an hour, but we want to make sure we leave time for some questions. So we're going to encourage that. I'll give you some instructions on how you might ask questions throughout the webinar. But first, I'd like to go ahead and introduce our panel today. I'd like to first start off with introducing Carrie Lynn Coleman, who is the president of Wellscreen, Inc. Carrie Lynn Coleman is a former staff at the Office of National Drug Control Policy, and she also was a presidential advisor on prevention and substance use. We're also pleased to have join us today Darcy BIRT, who is the program coordinator for the Lafayette Family Preservation Court in Louisiana. I've had the pleasure of working with Darcy for many years now, and so pleased that she'll be able to join and share in her lessons. She's also joined by Pamela Russell, who's a case manager with the Lafayette Family Preservation Court. So thank you all ladies for joining us today. And again, thank you to the participants who have joined in the middle of your day, wherever you might be joining us from. So we're grateful to have you, and we hope to cover quite a bit. But before we get into the content, I wanted to just cover some of the logistics for today's webinar. First of all, we are certainly going to be encouraging you to participate in this webinar throughout the discussion. So we'd like you to ask questions during the Q&A portions, in which we might be able to unmute your microphone if you use the raise hand function, which you should be able to do when you go to participant. If you select participants at the bottom, there should be a button there for you to raise your hand. You can also, throughout the discussion, in case you're like me and you might forget your question if you wait too long, just go ahead and submit those questions either using the Q&A function or using the chat function. We have staff on the phone, as well as us panelists who will be monitoring the chat function and the Q&A, and we'd love to be able to address all of your questions today. If for some reason we're not able to get to all of your questions during today's live webinar, you can go ahead and email those questions to info@collaborateandgrow.com, and we will respond to those questions as soon as we can. So that's a little bit of the logistics. I'd like to move into today just kind of what we're trying to cover and leave you with. First, we hope that you'll understand the early implementation lessons and some of the data findings from Lafayette. Learn how to establish a systematic and structured substance use disorders and mental health screening protocols for families entering or coming into contact with the child welfare system. We hope that you'll learn how Wellscreen can be used to easily conduct the evidence-based practice of SBIRT, and to increase opioid knowledge and connect families to appropriate and quality treatment resources. And then lastly, learn how to routinely monitor program effectiveness using administrative data that's provided by Wellscreen. So that's what we're hoping that you'll gain from today's webinar. So why is this important? And many of you, looking at where you've come from in terms of your registration, these are probably not new ideas or new concepts for you. Just a little bit of background, if I haven't had a chance to meet you, prior to coming to CBU, I've spent over 20 years working in child welfare. I started first in residential treatment with kids ages 6 to 12 at a level 14 lockdown facility, 30-bed facility, and then moved into Child Protective Services and worked from a line investigator all the way into a county administrator, and then spent the last decade working across the country on helping communities implement evidence-based practices, specifically in the nexus of child welfare, substance use, mental health, and the court systems. And throughout that work and the research and experience that I've had, what we see and what's notated in the literature is that children whose parent have parental substance use disorders and or mental health disorders are co-occurring have greater likelihood of foster care placement. They tend to be less likely to reunify once they do come into foster care or into the child welfare system. If they do reunify, they're often less likely to re-enter the foster care system. And there's a greater likelihood of termination of parental rights for those parents who do have a substance use disorder. What we find also in the literature is that it's really critical to try to combat some of those outcomes is that we must identify parental substance use as early as possible so that we can provide the parents, the families, the services they really need in order to be able to, first of all, maintain custody of their children in their home, which a lot of programs are trying to do, and you might have picked up on this when we introduced the Lafayette Family Preservation Court, and their first goal is to maintain families together. And in order to do this, though, we must identify substance or mental health disorders and then connect them to the appropriate level of treatment to mitigate some of those and begin treating those disorders. So timely referrals to treatment and treatment completion are robust predictors in the child welfare system. If you look at the pipeline for a child who enters foster care because of a parental substance use or alcohol disorder, and then you look at the likelihood of termination of parental rights, the number one predictors of reunification is treatment completion. And there's some other factors in there as well. Some of those include family time or increased visitation, but the most robust predictor is going to be completion of treatment. And to be able to complete treatment within the statutory timelines means that we got to identify families early on in the child welfare system that do have that substance use disorder. And a big part of those families that we often go missed is those parents with a moderate substance use disorder. So unless a child is removed due to parental substance use, I mean, it's pretty explicit, right? That there's the allegations came in because of parental substance use. Maybe the parent's been arrested. Maybe there's been a baby who's born prenatally exposed and the referral's coming in from the hospital, or there was, some history of that, an arrest made, those types of things. Substance use problems are often missed. And in one study, it showed that only 18% of caregivers were correctly identified by the caseworker. And so having tools available for child welfare to use an evidence-based protocol that goes beyond just a drug test screening that can be easily manipulated is really critical for child welfare to early on identify or detect a substance use and mental health disorder and then appropriately treat that. I want to talk about a little bit of the scope of the issue, and starting with just kind of the big picture of the scope in America. And this data is from 2016. There are new data. The data really haven't changed much over the last couple of years. But what you'll see is that this data is showing about 8% of Americans having some type of substance use disorder. That number jumps up to about 21 when you include alcohol and substance use. So it's a pretty robust issue in our country now. And of course, since, for the last decade or so, we've been dealing with the opioid epidemic. That hasn't gone away, certainly. There's many concerns right now with the stay-at-home orders and the quarantine and social isolation. And we know that substance use disorders is a disease of isolation. What these numbers might look like moving forward 2-3 years and what those effects might be on children. So those of us looking at these national data sets continue to be concerned and are uncertain what the future might hold for these. This is some historical data, just looking at numbers of children in out-of-home care in the United States, starting back in 2000, moving forward into 2018. And you see that we did have that decline around the mid-2000s of kids in foster care. There was active efforts to either prevent the removal of children and or to reunify more quickly children, and then also help with those long-term to help older youth exit foster care. And so we saw some declines. But then around 2012, also at the same time that we really began to see and experience the effects of the opioid use disorder, we began to see those numbers of children entering foster care tick back up. And of course now, here we are, we find ourselves in July of 2020, now in the family first era, and many states have begun implementing family first. And so researchers and scientists and child welfare industry are going to be looking what this trend line will look as we move into this new era of child welfare. Here's some data on the prevalence of parental alcohol and drug use, again, going back to that same timeline of 2000, moving all the way into 2018. You'll see that that number is more than doubled in terms of the number of children identified as being removed as one of the reasons for removal is parental alcohol and drug use. Again, though, going back to other national data and other research is that unfortunately, unless it's just prominent in the case or explicit, substance use often goes unidentified, and it often goes certainly unreported in national data sets. This data set happens to be from the AFCARS data set. AFCARS 2.0 is being released, and states will need to be reporting more robust outcomes beginning in 2021. But this is the data we have, and you can see from state to state, there's wide variety in reporting. From Arkansas reporting nearly 70% of its removals due to parental alcohol and drug use. In California, it's somewhere around 11%. In Louisiana, it's well under 11%. And in fact, in Louisiana, in the data that we pulled for 2018, it showed only 410 kids in the whole state being removed due to parental alcohol and drug use, and having had the opportunity and the privilege to work all across the state of Louisiana with many different professionals. And of course, today on our panel, you'll hear from Darce and Pam. We know that that data is not accurate, and that has to do with the way data is captured in the AFCARS data set. So we know that national average of 36% is very low, and we think that there are ways to better develop systematic screening protocols at the very front end of your child welfare system to better identify and report on those children engaging or touching the child welfare system due to parental alcohol and drug use. And so, and when we do that, we have better outcomes. And this slide is taken from information from a SAMHSA resource called Screening and Assessment for Family Engagement, Retention, and Recovery, or SAFER. And there's opportunities for child welfare to improve those outcomes that I discussed earlier of higher rates of foster care placement due to parental substance use, of more likely to reenter the foster care system, more likely for termination of parental rights. So how we improve those outcomes are, number one, increased identification of the substance use disorder as early in the case as possible. Increased communication between the child welfare system and the treatment. Improved decision-making by child welfare professionals. The biggest tool right now that child welfare typically uses to determine whether a parent has a substance use disorder is a drug test. Unfortunately, a drug test tells us very little about the parent's ability to parent their child. Number one, it doesn't tell us a lot about the severity of the substance use. Really, all that it tells us is that a parent used a particular substance within a particular time frame that the substance was tested for. That's about all that we can. Now, drug testing, don't get me wrong, is a great tool for managing a client once they're engaged in treatment, but it's not a great tool in terms of diagnostics. We know there's opportunities for improved child welfare outcomes when we're able to reduce the time to treatment for parents. So again, early identification and then connecting parents quickly to and timely to treatment that is quality treatment. So we're going to talk about both of those today on how you might be able to implement an SBIRT protocol using WellScreen that do all of these things, and that hopefully will lead then again to parental engagement and retention and treatment as needed, and then reduce that risk of maltreatment for children and increase family stability, reunification, and overall well-being. There's obviously some key legislation that impacts this. I alluded to this earlier, the Adoptions Safe Families Act, which or ASFA, which requires state agencies, child welfare agencies, to move to a permanent plan if the child's been out of home for 15 of the last 22 months. In many states, that time frame is much shorter. In some states, actually, it's only 6 months. If a parent isn't making progress towards reunification, the state moves to file a petition to terminate parental rights. So there really is no time to lose. So that timely access to treatment, quality treatment, knowing the appropriate levels of treatment is really critical for the child welfare population due to ASFA and other state regulations. And then, of course, now we have the Family First Prevention Services Act, which does provide 12 months of funding for the prevention services, specifically funding substance use treatment for parents identified as having a substance use disorder, and providing those preventative services to try to keep or eliminate the need for children entering the foster care system. And so here are some of the kind of the highlights of this. At this point, this is probably old news for many of you. This was signed into law in February 2018, but it does provide some services for both substance use, mental health, and in-home services for families. And so there are many states now that are moving into implementation of Families First. And I talked about the ASFA. There's really just no time to lose. So here's the thing. After now decades and really going through several what we might call epidemics, there was the cocaine epidemic in the 80s, and we saw the explosion of the child welfare population. That was the bad news of that epidemic. The good news was that there was federal investments, which part of that investment also came research and evaluations and publications that helped us understand how to treat these families best. Then we went into the methamphetamine epidemic. One of the programs I had the pleasure of directing was the children affected by methamphetamine, and we learned even more about how to best serve these families. And then we moved into now the opioid epidemic. Currently have the opportunity and the privilege of serving as a consultant with the Opioid Affected Youth Initiative, which is another national initiative funded by the Office of Juvenile Justice and Delinquency Prevention. And we're learning even more about how to treat these children and families through that initiative. But what we know works is really this idea of a systemic approach. When we talk about systemic, what we mean is it's not relational or individualized to the particular child welfare case manager, and that it's in a program or systemic in which the entire child welfare system is able to systemically screen universally all parents that they come into contact with to identify those substance use disorders early on. One of the programs that I directed was called the Statewide System Improvement Program. Again, that program was funded by the Office of Justice Programs. And we had the privilege of working with 5 states and the territory of Guam. We did some amazing work in terms of rolling out universal screenings in the child welfare systems. We rolled out lots of trainings to try to train workers on how to do SBIRT. We're going to hear about what SBIRT is in just a minute from Carrie Lynn. We worked with the local community treatment providers to have warm handoffs because we know that works. We also looked at how we can develop supportive parent-child services. We know that parents and families do better when the parents and children are together or spending as much time together as possible, and actually treatment retention and treatment completion go up when that happens. And the need for that cross-system collaboration. And we did some great work under that program. Unfortunately, very little to almost none of that work was able to be sustained. A lot of the reason for the inability for that work to be sustained across many of the states, not all, was the lack of infrastructure. That the using legacy SACWIS systems or the lack of a CWIS system, or Child Welfare Comprehensive Child Welfare Information System, Comprehensive Child Welfare Information System, or CWIS, that lagged behind in those states. There was no place to really document whether screenings had happened. There was no place to know what the results are of those screenings. There was no way to know if a parent had been referred and then what happened as a result. There was no follow-ups that could occur in those states with that program. This is after millions of dollars of federal investments. And when I left that program, I was very frustrated that we worked so hard, and the people in these states at the ground levels, well-meaning, well-educated, caring judges and caseworkers and treatment professionals and administrators, and so little was able to be sustained. And that led me to connect with Carrie Lynn, who was presenting at a national conference, and hearing her background and her expertise at the national level of working in the prevention field, and finding out how you can use WellScreen to do all of these things, and most importantly, have the administrative data function to actually know that it happened. So as a supervisor or a manager, knowing that workers actually did systematic screenings, we could tell what the results were, and then we can see what happened to those families, was quite amazing to me. And so with that, and these were the challenges that we faced. All of these things, including the child welfare turnover. And so those states where we were trying to implement those standardized screening protocols, we did a lot of trainings. In fact, in one state, I went up and down the state multiple times training, not just myself, but my colleagues and staff from those states, training on what a substance use disorder is, understanding brain science of the substance use disorder, how to conduct evidence-based screening, where to document that. Unfortunately, about the time we got through an entire state, the state would suffer 25–30% turnover in its workforce. And so having a system that requires very little training at the onset was critical. And again, there's weak handoffs and referrals, no place to document whether a referral actually happened or not. And then just this lack of data tracking overall, and whether these protocols were able to be sustained, whether they're put in place, whether they're to monitor these protocols, really challenged our ability to sustain those great efforts. And so with all of that, it's my pleasure now to introduce to you now and hand this off to Carrie Lynn Coleman, who's going to talk about some opportunities. Thanks, Carrie Lynn.
Thanks, Phil. So yeah, given the number of parents that are struggling with substance use and mental health disorders, and the kind of lack of universal screening that's happening now, we really do feel like that there's an opportunity for us to intervene early and improve outcomes using SBIRT. So I'm going to talk about what is SBIRT. So Phil, if you'll advance the slide. So SBIRT is screening, brief intervention, and referral to treatment. So it is a protocol, intervention protocol that's been in practice for over 30 years. So SBIRT is evidence-based. I think that is one of the key pieces that has really drawn me to the use of SBIRT for a practice. As I mentioned, it's been in practice for over 30 years. We have significant evidence across that time that shows that it can be effective at reducing substance use, high-risk substance use, and then also making sure that we're getting individuals to treatment and we're reducing substance use. It's supported by the World Health Organization, the Department of Health and Human Services here in the United States, as well as the Preventative Services Task Force. There was a recent study that was conducted by SAMHSA where they actually looked at a million individuals who had been screened over 5 years in a variety of settings, including community-based settings, but also primary care practices. And what that found, that study found, is that across those settings, they had positive outcomes for the participants. And they found also that it was really cost effective. So it was a way to intervene early, achieve documented outcomes, and also achieve cost savings across the system. So SBIRT has 3 steps. The first step is screening. That is, again, we want to use universal screening in a population. So if you're in a child welfare setting, you're going to want to screen 100% of the parents who enter your system. If you're in a school, you're going to be screening 100% of your students. So it's not meant to be a screening for people who you believe are struggling. Instead, you're going to screen 100% of your population. And you're going to use, ideally, a evidence-based tool. And later on in the presentation, I'll go through some of those evidence-based tools, but there are lots of tools out there. So you screen 100% of your population. You first, using that screening tool, typically you're going to identify those who have not used any substances either in their lifetime or within last year or 30 days. Those individuals won't get a further screening or what is more of an assessment. If they've used a substance within the last 30 days or a year, depending on the screening tool, they'll then go into a further assessment. And the purpose of the assessment is not a diagnostic tool, but it is supposed to identify individuals based on their risk level. So are they at low risk of experiencing negative outcomes from their current pattern of use? Are they at moderate risk of either progressing on to a substance use disorder or experiencing other negative outcomes, or are they at high risk? So we use the screening tool to kind of identify what category that individual falls into. Then based on that risk score, the caseworker or practitioner will do a brief intervention. So that brief intervention is anywhere between 5 and 15 minutes. The goal of that is to change, kind of bring awareness to the issue for the parent or caregiver in the case of child welfare, or to the patient in terms of a primary care setting. So you want to bring awareness to the issue and connect the use of substances with whatever negative outcomes that individual might be experiencing. And then you're really going to work to create some desire for some behavior change. So you want to move them into a low risk behavior. And obviously it also includes some education around what are low risk patterns, what is low risk use. Most Americans don't recognize that there are low risk ways to use substances. And so, well, alcohol in particular, and then of course abstinence is best for most substances, but around alcohol, there are low risk guidelines. And so the brief intervention also includes that education. For a small subset of that population that you're screening, they are already going to be in need of some further intervention or specific treatment. And in that case, you use the screening tool, and then you use the brief intervention to kind of generate that desire to go to treatment, and then you do that referral directly as part of that session, and I'd help them identify appropriate treatment resources. So those are the 3 steps for SBIRT. SBIRT can be done without having licenses, that kind of thing. So a caseworker is totally capable of implementing an SBIRT protocol. So in implementing SBIRT, we really are able to reach new populations. Most substance abuse treatment currently has been with persons with more severe substance use. But what we know with SBIRT is that you can do interventions earlier on in a use, when someone's exhibiting high-risk use patterns, the earlier you intervene, the more likely that you can get them to change that behavior and not progress on to a substance use disorder. So SBIRT targets those with non-dependent substance use and then gives us those strategies as part of that protocol to intervene and do a very brief intervention to change those patterns of use to kind of avoid some of those longer term negative outcomes. Within WellScreen, we are using a book, which is the Brief Opioid Overdose Knowledge Questionnaire. I will go over some of the details and research behind the book, but we know that book can be used when a client in the screening endorses that they have used or are using opioids. And the book is a knowledge questionnaire and can lead to its own set of interventions based on the outcomes of the book screener. So this is the kind of care continuum that was developed by the Surgeon General's report on alcohol, drugs, and health back in 2016 when he released his report on addiction in America. You'll see, obviously, we want most people in the kind of left-hand side of the screen where they are experiencing positive physical, social, and mental health. And among that population, which is honestly the majority of the US population, we're going to be focusing on enhancing their health and providing primary prevention. So those are things like doing primary prevention when kids are growing up to make sure that they're not beginning use earlier in their development. We're doing primary prevention among college students to give them the tools they need in order to handle kind of life events without relying on substances. We're doing things to increase wellness and positive physical and mental health. When people begin to misuse substances, then we move into the early intervention. And so the SBIRT really is targeting those individuals who have begun misusing substances. So the idea with SBIRT is that you target those who are using substances at a high risk, but they're non-dependent at this point. And the research really shows that if you can kind of identify those individuals and do these brief interventions, you can successfully move the majority of those individuals into low risk use patterns, which then kind of keeps them in and moves them back into that prevention, enhancing health category. Of course, about 5% of the US population, if you were to screen kind of a sample of the US population, about 5% of them are already using substances in a way that is beyond misuse, and they have already developed a substance use disorder. Those individuals are going to need treatment, and then hopefully that they transition into recovery after they've received effective and completed effective treatment. So what does SBIRT look like in child welfare? What we want to see is you first start with screening. So you're going to assess all parents as they enter your system at kind of various points of entry. So you want to screen them to assess them for risky substance use behaviors. And as I mentioned, you're going to want to use a standardized evidence-based screening tool. Based on those risk results, you then do a brief intervention. Again, a child welfare professional can easily be trained in the SBIRT protocol and can do this brief intervention. So the child welfare professional engages the parents who are showing that risky substance use behavior, and they begin doing the short conversation. They provide their feedback and advice. Those individuals who screen initially as low risk, you don't just kind of end it there. The idea, even with parents who screen low risk, is to give them positive reinforcement and recognize that their use patterns are kind of in that healthy range. And you can always provide education about the risks of substance use, especially as I think Phil mentioned, oftentimes when families become engaged in the child welfare system, it's a heightened stress time. And so often individuals use substances to relieve that stress. So even if they're screening at low risk at that moment, some bit of education is warranted for anyone you are able to do that with. And then there's that referral to treatment. So that smaller portion of the population who you identify as already being at the highest risk or already having a substance use disorder, the child welfare professional helps to identify appropriate treatment resources in the community. They provide, even some individuals may need brief therapy, so you may not be doing, referring to an inpatient, but more a therapeutic setting. And so the role of the child welfare professional is to identify those local resources and then encourage the parent to access those resources and doing that warm handoff. So research shows that there are numerous benefits of SBIRT. The first, of course, is the substance use. So the research shows that we reduce alcohol and drug use significantly among populations where SBIRT has been implemented. It's also shown to reduce accidents, injuries, and overuse of the emergency room. We also encourage, most of my comments have been focusing on substance use, but we also include screeners for depression. And so if you identify an individual who has signs of depression, you can also intervene in that. And by addressing either or the substance use or depression, you're going to see better outcomes. We've seen significant investments in and cost savings when you implement SBIRT. So for alcohol, it saves for every $1 invested, you can save up to $20 for every dollar invested. So it's definitely cost effective, and that's what that SAMHSA study showed as well. So other potential outcomes and outcomes shown in research is that reduces work impairment, reduces DUIs, and then also improves neonatal outcomes. So there are studies after studies, like I said, 30 years of research that shows how effective SBIRT can be among numerous populations. So the benefits of SBIRT for practice, specifically for the child welfare, is that it increases caseworkers' awareness of substance use issues by simply going through the SBIRT training, which is an 8-hour training. You learn about substance use disorders, you understand kind of risk factors, and also how to provide a brief intervention. So many substance or child welfare workers, caseworkers, have various backgrounds and may not have actually received any training in substance use prior to entering the child welfare workforce. So by just doing SBIRT training, you're going to be increasing that awareness of substance use issues, and then also that as an underlying condition when they're approaching and working with these families. So it gives caseworkers also the systematic approach to addressing substance use, instead of just perhaps noticing paraphernalia on a house visit, or suspecting that the underlying issue in that family is a substance use disorder. This really gives a place for caseworkers to start and gives them an opportunity to open up that conversation. And it is consistent across all of their cases, making sure also that they don't miss that issue because it's so well hidden within a family. So as I mentioned, there are a variety of screening tools. Within WellScreen, we use the Assist. It was developed by the World Health Organization. It is available in multiple languages, so not just English and Spanish, but they have it in a variety of other languages. It also, the reason I like the Assist is that it doesn't just screen for an individual substance. So for example, some of the screeners will only screen for alcohol. Others will only screen kind of for general substance use. This tool allows you to identify specific substances. So it asks about a variety of substances, and then based on each substance, it goes through a risk assessment for each substance. Others, though, that are available and may work better for your individual community are the audit and the DAST. We also implement the CRAFT, which is specific to adolescents. The CRAFT was developed by Boston Children's Hospital. So you can use the CRAFT for anyone aged 12 to 18. And then there's the TWEAK, which is used specifically for pregnant women. So that can be used if you have a pregnant woman who is in your care. So this is just an example of the potential screening tools that are available. As I mentioned, we also integrate the book, which is the Brief Opioid Overdose Knowledge Questionnaire. The book was developed by researchers at Johns Hopkins University. They recognized that most of the interventions related to opioids were really focused on the distribution of naloxone. And if you're familiar with substance use and the opioid crisis, naloxone really is not a preventative tool. It certainly does a great job of preventing overdose, but it doesn't prevent substance misuse. It doesn't prevent substance use disorders. It simply prevents an individual who is already obviously misusing that substance from overdosing. And so we want to move that intervention way earlier in the timeline. And so the book is a great tool to do that. It has 12 true-false questions, and they assess the general opioid knowledge, general opioid overdose risk knowledge, and then overdose response knowledge. If you can advance it, Phil. What the research showed from the researchers at Johns Hopkins is that patients who are receiving opioids are at an increased risk of opioid-related overdose. What they also identified was that the knowledge among those who are illicitly or legally using opioids is actually lower than those individuals who are illicitly using opioids. So one of the important elements of this is that even if you had a parent who you're working with who has a valid prescription for opioids and they're using it within the recommended guidelines, that individual likely has less knowledge of their risks and potential response if they did find themselves in trouble than an individual who was misusing or accessing those opioids on via illegal means. So it's real important that there's this kind of population of individuals out there who really could benefit from this knowledge because they are using opioids and they're not as aware of their risk. The research also showed that they didn't require a clinician to be trained in the content knowledge in order to effectively administer the book. And it is a great opportunity for to be used to start that brief conversation. And then they even used the book for screening and then used an educational intervention. And they found that those educational interventions are informative, produce sustained knowledge gains, and clients accept the use and the information they achieve from the book. So we find it to be a really great addition to the WellScreen tool. The way it's used within WellScreen is that if an individual screens endorses that they've used opioids in the last month, then they complete the assist screen, which then gives us a risk score related to their opioid use, and then it automatically takes them into the book. And so then they complete the book, and then the system will give the caseworker information about their risk score related to opioids as well as their knowledge score related to opioids. And so then they have the information they need in order to move forward with that client. So just another note on WellScreen, since that's what Lafayette has been using. It is a tablet-enabled screener tool. So you first start with that assessment and identification. So you use the screener and integrate those evidence-based tools like the Assist, Craft, PHQ, PHQ-A, which are for depression, and then the book as well can be implemented. So you do the screener and it provides the skip pattern for you, so you don't have to worry about trying to score it and figuring out what is the next question you're supposed to ask, as many screeners have the caseworker do. So it takes about 10 minutes, and then you get an immediate report of the results for the parent or caseworker. Based on those results, the caseworker can do education and do the brief intervention. There is evidence-based education module integrated in there. There are fact sheets that can be printed for the patient or parent. And then there is a step-by-step kind of walkthrough for the caseworker, just as a kind of reminder on how to implement a brief intervention. We have created a partnership with the National Association of Addiction Treatment Providers, because treatment resources are kind of difficult to identify throughout the nation, and especially making sure that we have licensed and accredited resources that are being recommended to clients. So we have access to the NAATP's treatment database, and so we only include the private treatment facilities that are on their list. And then we use the SAMHSA database to include the public and treatment resources that are public. We have all of the information about those treatment resources, so you can match your parent based on their criteria in the screener, as well as everything from zip code to gender to need for childcare. And then you can provide an electronic referral and print the information. There's also the ability to do a 60-day follow-up screen, so you can compare the initial screening results to the 60-day follow-up to measure the effectiveness. And what's great about today's webinar is that we'll get to hear from Lafayette, and really we've done the analysis of their follow-up screens to show how effective SBIRT has been within their child welfare system. So with that, I will move into the lessons from Lafayette with Pam and Darcy.
Good afternoon, I'm Darcy Bird. Thank you for being with us today. I see a lot of people from Louisiana, a lot of people from Lafayette. I want to thank everyone for coming. Thank you for Lafayette, especially for all of our DCFS workers who have supported us through this, and all of our community support that we have had. We started our program in 2010 with the original thought. I was going to say, Phil, you want to move to my screen? Oh, sorry. The original thought for our program was to have or work with substance exposed newborns. Within the first couple of years, we realized there was a huge need for families that were coming in with very high risk. So at that point, we reevaluated our program. We had Children and Family Futures come in with at that time. Phil was with them. They came in and evaluated our program. We looked at it. We started working with both men and women. We at that time also looked at it and saw that we should probably start working more with keeping the children in the home versus working with just foster care. So at that point, we also took the thought of just what if we work with, or what if we focus on family services. So majority of our families come in as family services. We do take foster care, but the judge that we work with, Judge DePlanche, wants to work and see what we can do to keep the children at home. So we began expanding all those services to those families. DCFS was great. We got with our team, expanded with the child investigators, their supervisors, their workers. They were all on board with working with us. So at that point, I mean, we just exploded. We started getting all kinds of screenings done. We worked with a whole bunch of screening tools. They were great tools, but they just were not working for our program. We couldn't, a lot of the tools we used, we couldn't go into the hospitals, we couldn't go into the homes, we couldn't go into the courthouse and do those tools. We needed something that fit our program. And a lot of what we found is a lot of the tools that work with specialty courts didn't necessarily work with the kind of, work with the kind of case management we wanted to do. Didn't give us or help us build the rapport that we wanted to build with our clients. We realized we work with a special clientele. We work with parents. We work with a lot of times first-time parents. We needed to build that kind of special bond with those parents, and the tools that we were using weren't helping us build that. For those of you who are just starting a family preservation court or family dependency court, the most important thing I can say to you, and I'm blessed to work with a case manager and a recovery coach that have just this ability to work with parents and talk with them and get to know them. And that's the biggest thing I can tell you to do, is become just familiar with their families and understand them, and your case management will just, it'll become something just easy. And that's where the intense case management just, it does, case management will start to do itself. So we do our drug screening, we do our parenting components. With all of that, and with the screening tool we realized that we needed, we reached out to, I think I had sat in on a webinar, and Phil was doing it. Phil, I don't know if it's on the next screen, on the next slide. Oh, okay, go back to this one, but I'll talk about how we found the well screen. I had sat on a webinar and heard about the well screen, and it was everything at that point I realized we needed. It didn't have so much of the criminal as much as it had the components that met with the families that we worked with. I felt that it was more family friendly. It was easy for our clients to understand. It felt like at that moment, I found something that was finally going to work for our families. So I reached out to Phil and said, hey, can you please tell us more about this tool? And he gladly did. At that point, with Pam's help, because she does the screenings for us, we sat down with them, started learning about it, realized that this would already coincide with what we call the AIMS packet. Pam's going to talk more about that in a little bit. And it would just work for our families. Since 2010, it'll be on the next slide. We have worked with 246 clients, our parents. We prefer to call them parents, not clients. Out of that, we've had 351 children. A majority of those, I'm happy to say, that we have been able to keep in the home. Like I said, the judge that we work with, Judge Aponche, prefers to have those children placed in the home than have them placed in foster care. We find that the parents are generally more willing to work the program as an added benefit of having those children in the home. We've had 100 graduates and 25 babies born without prenatal exposure. Some of those women come pregnant into the program. Some of them get pregnant within the program. But I mean, we are happy with that number. With the 100 graduates, we currently do have some clients in our program. We're slated for 38 clients at this time. We just got a new number. We were slated for 35. Now we're slated for 38 this coming fiscal year. The 246 parents currently, I would I think at this moment we have 33 active parents. Some of those are couples, some of those are single parents. Some of the families are parents remain couples within the program, some of them separate within the program. But we always remind them that when they come into the program that whether you remain a couple, you're always going to remain a family. So what we're trying to do is preserve the family, and that's what the end goal is. You want to go to the next slide? Okay, I'm going to let Pam take over. I'll jump in on a couple other one of these.
Hi, I'm Pam. I'm the case manager for family preservation. So I'm kind of just going to go through the process of exactly how we implemented the well screen into our program. So the initial referral comes from DCFS. If there is suspected substance use involved in the case, whether it's a baby born exposed or someone makes allegations of abuse or neglect due to dependency issues, they refer the client to me. And what I do is the initial meeting, I kind of sit down and I give the clients a packet. It's called the AIMS packet. And the AIMS packet is a packet that was developed from our data collection system in the state of Louisiana. It just lists demographics. It has a list of the children. One of the important things that is on there as well is we ask the question through each of the children if any of them have ever been exposed before. So we're able to have that as kind of a starting process if they have more than one children, to know that they've had more than one substance exposed newborn. So one of the things that is in the AIMS packet is a drug history. It kind of lists the age of onset of drug use. We start with, at what age did you start drinking alcohol? I usually go into, do you remember the last time that you drank? And then with that, I kind of step back and say, well, how often do you drink? If you have a past history, that's fine. Everyone's allowed to have a past. We just kind of want to see where you're at and if, where you stand coming into the program. And then how often you drink and how much do you drink? But obviously we list that for each separate substance that is involved, methamphetamines, ecstasy, everything. Next, what we do is once I complete that AIMS packet with them, I go over to the well screen, which I perform the ASSIST, the book, and the PHQ-9. And the ASSIST, it stands for Alcohol, Smoking, Substance Involvement Screening Test. So what I do is I've already received a drug history from these clients. So I'm able to do another drug history with them through the well screen program. And obviously if they trigger yes for any opioids, then that's when it would prompt the book to be administered on the clients. And it's kind of just a way for us to go over. I let them know ahead of time that there's no right or wrong answers. It's okay. Nobody's seeing this. It's just me. And what I'm able to do is provide them with some education right there at that moment of the things that they're putting into their body that the majority of them don't even know the effects of what it could happen if you misuse it. And then the PHQ-9 is a patient health questionnaire. This is kind of where the mental health part comes into the play of the program. I can see kind of if they're feeling depressed, down, hopeless. And it also asks, are you have any thoughts of, hurting yourself or death, dying, or suicide? And so obviously if they answer yes to that part of the screening, I go ahead and stop and we go ahead and make a plan and see where they're at. And I refer them for the appropriate programs or whatever they may need. So the education packet, once you complete the well screen, everything that you have answered yes for as far as substance wise, it prompts an educational packet that you can actually print out and provide the client. So you're giving them some form of information on the substances that they're putting in their body and how it can affect them, early on, as well as, if you use it in the future as well for long periods of time. So when they come in, they may not know as much about what they're putting into their body, but when they leave, we're able to provide them with some form of education as to how, this is affecting them. It can affect their baby. It even gives an educational packet on tobacco. So the next part of the process, what I do is I get with the DCFS worker or the child welfare worker, and I let them know that we've completed the packet and this is what we've discussed. And that's the moment that we either refer them to a treatment center, depending on the severity of their use, or detox, whatever it may be. One of the referrals would be also for the family preservation program. I let them know that they are probably a good candidate for the family preservation program. They have acknowledged that they have an issue and that they're willing to, work a program in order to maintain their children in the home or to have their children placed back in the home more quickly. And then I provide that to DCFS, but also if they're not in family preservation and they also are not being referred to a treatment center, it also gives DCFS kind of a baseline of what they can use to put into their case plan to say that they have completed a substance abuse assessment. So it's kind of like I'm helping DCFS out in that aspect of being able to provide them with that actual packet that they can put in to the case plan as well as the file that they completed that. You can go to the next slide. Oh, I wanted to say something about a case example real quick. So something recently we did is with the 90-day follow-up is I had a client that was referred to us. She came in and she screened moderate low. I believe she had a first-time substance exposed newborn to marijuana. And come to find out when I did the 90-day follow-up with her, her drug use had increased significantly, and she also found out that she was pregnant again. So we were able to go ahead and intervene at that moment and let DCFS know, maybe what she's doing at this moment is not working, and she needs to be provided with some more services. So we were able to refer her to family preservation, in which she's going to be participating in the program and receiving services, as well as trying to maintain her sobriety and being held accountable in the program while pregnant. So that's just a case example that we've had of a really great outcome with the 90-day follow-up. Going to the next slide. What's working well with us, the flexibility of it. We're able to take this on an iPad as well as, it's user-friendly. Something we've implemented since the COVID started is that I'm able to actually send them the pre-screener through their email. So they're able to answer it independently on their own. And I'm able to see when they finish and we can go through the process. But as far as face-to-face is concerned, we're able to it's on an iPad. So I've been able to travel over to the courtroom if there's a parent that we've been unable to get in contact with, or DCFS has been unable to schedule with. I can actually physically go over there and be able to provide that assessment on the spot. And also I've been to the hospitals before the parents have even left the hospital with the child and provided that assessment to DCFS to see exactly where they're standing at as far as the significant, their level of substance use. It's user-friendly. Like I said, the client is able to complete it themselves. It's pretty straightforward. It doesn't require, as far as a whole lot of training, it doesn't require that you have to be trained in it. You can kind of read it. So it's a great tool for any worker or someone who may not be familiar with substance use. And we're able to use the data. We've used it well for some grant purposes. It's to be pulled quickly. You can put it in a pie graph, a chart, through an Excel spreadsheet. So we're able to pull that very quickly. You can break it down by demographics, age, gender, even location, specific substances. One of the main things about the screen that I really enjoy is that we're able to spend time building more rapport with the clients instead of just asking question after question. The main thing that when they come into my office, I want them to know is that this is not a punishment. This is for them to be here to receive services, to make them the best parent that they can be. So I like that it gives me the time to be able to spend just kind of getting to know them. I always like to ask them, why are you here? I want to hear their side and see where they're, why they feel like they're here. And then, it gives you an ability to know the client. And also they tend to maybe speak more clearly with me, or they're able to be more honest with me than they would have been with their worker. So we can go to the next slide. And some of the things that the challenges and the roadblocks that we faced during all of this is the follow-up. So the 90-day follow-up. When I first started started using the Well Screen, I did not give clients kind of a heads up that, hey, I'm going to be calling you in 90 days to follow up and just see how you're doing. One of the things that we run into is that they change their number. We're not able to get in touch with them, or they'll just flat out hang up on you. They don't want to talk to you. So another one of the honesty factor is that the initial screen, you want them to be honest with you. You want them to feel comfortable. And so I find that on the follow-up screen, they tend to not be as honest, especially if DCFS is no longer involved. But that we are still able to provide them with a service in the event that they say, yeah, I'm still using, yes, I'm still having issues. I can make the actual referral at that moment for a treatment center. It doesn't necessarily have to be, reported back to DCFS. We can make it to the treatment center. So that's just some of the roadblocks and the challenges that we have faced with the 90-day follow-up is that, they change their number or they're not willing to participate. And so I think some of the lessons learned through that is that, you want to start off with a good respect factor. I respect you just as much as I would like for you to respect me. And build that rapport with them and let them know that you're here to help. You're not here to cause more grief or issues than they already have. Another thing is I want to make sure the clients know what to expect. They know what to expect from the next step. So you've met with me. I'm going to send this to DCFS, and this is what you should expect next. And then, I'm able to report that to DCFS that, they already know that they're appropriate for the program or they should be referred for the program or substance treatment. And then another lesson would be our time management. In the beginning, we were having some issues making sure that we were doing the 90-day follow-ups pretty effectively and quickly. And so now we've managed to make sure that we get that set in place and we're doing that 90-day follow-up within that 90 days. That way we can make sure they're still involved or not involved, that they can receive the services that they need. And using the data effectively. Like I said, we've been able to pull our data from the well screen for the past year and use it for grant purposes, for funding. It's right there. We can show the amount of clients we screen who are low, mild, or moderate, or high. And so that's kind of where it's been some lessons and some challenges, but at the same time, it's worked really well for us. And we've been able to, provide DCFS with a service that I do not think would have been worked as well in the event that we didn't have the well screen tool to provide to them. So that's kind of just the general idea of how the well screen fits into our family preservation program. It's easy to read the results. So we're able to give that to the clients and to the workers, and they can take it and implement it into the case plan.
I wanted to jump on real fast and go over with the data. Recently, we've been looking at starting a new track. And so we were able to pull a lot of information from the well screen when trying to develop the 3-month track. And with Phil's help, just when actually we were talking about putting the slides together for this training, he helped me look at some of the information that he had pulled and showed me where when putting the 3-month track together, we're looking at a low risk track. He said, look, this is where your information, he's like, you have, the perfect clientele for the 3-month track because these are the people who are falling into it. These are your numbers. And it was something that it was a light bulb. I was like, oh my goodness, without this, I don't know if I would have had these numbers, because when Pam's doing the initial screening, they're giving the information right off the bat. And so now I am able just to go into the WellScreen database and pull all of this information from just their first screens and then their 90-day screens and see where we're getting all this information from. So it was great that I was able to pull that information and email it to the person that's helping us put together the grant and say, hey, look, these are our numbers that we're getting from the 206 screens I think that we've done since we started using the WellScreen tool. And this is our low risk. These are our low risk parents. The numbers are huge. We have the clientele for this track. So the data that we're getting from this particular tool, it's great. It's amazing. It's wonderful to look at.
Awesome. Well, thank you both. And as we now kind of jump into some of those initial findings, and Darcy, that's a perfect kind of segue in there. And I invite both Darcy and Pam to jump in as we kind of dig through these findings. And I'm going to go through them kind of quickly because we're we're kind of short on time, but I did want to just say that this data is coming straight from WellScreen, as you'll see at the bottom of each of my slides, the source and when it was retrieved. So as Darcy just said, since July, so they've been up and running for 1 year, and it was, it's like with any program, they started slowly in the first month and then just picked up some steam. They've also been able to do a great job in Lafayette of continuing.
I want to add something real fast. There, looking at the people who are on the training, there's multiple people from DCFS, and I saw multiple supervisors and child welfare, child investigators on. So these are the numbers that they're sending us.
Awesome. Yeah. So yeah, great partnership to be able to get those referrals. In other communities where you don't maybe have a family preservation court, you could even move this whole process up into the child welfare system at the DCFS level even. But what you've seen here is 206 screenings, and of those, about an 81% fail rate, meaning they screen moderate to above on the assist. 35% failed the book, 13% failed the PHQ-9, which is again the depression screener. So an overall about 45% fail rate. What we did is we just took the initial assist results and broke it down for those who had failed the screen. So of those 206 screens, you'll see here about 36% are failing due to cannabis, 5% cocaine, over 20% due to stimulants, which I think historically methamphetamine has been a high percentage drug of use in the Lafayette area. So that wasn't a surprise to them. But what we're also seeing is nearly 20% of all the clients screened. So again, this is fairly universal. Every parent referred to the Family Preservation Court is being screened, and nearly 20% are failing or screening moderate to high risk for opioids, which is a fairly high number if you look at it for national statistics. Then we looked at it just by age, kind of broke it down. Not surprising that the 25 to 44 age group is the most prevalent age group. That's kind of your parenting group. Their second would be that younger population, 21 to 24. And again, the majority of those 25 to 44-year-olds are screening moderate risk. And I think Carrie Lynn alluded to this earlier, as did I, in our initial research showing that only 18% of families are identified correctly early on in the case. Only 36% of families are identified, 36 to 38% right now at the national level are identified as coming into the system due to parental alcohol and drug use. It's oftentimes this moderate risk population that's missed in current practices in child welfare. And what happens then is child welfare gets involved with the case, and then these moderate risk parents who haven't tipped over to high risk, which becomes much more explicit when you're in that high risk behavior. This moderate risk population, having the chance to intervene early with those before the stress factors of the child welfare intervention begin to exacerbate that substance use disorder. So identifying these families is just critical. And then here again, we looked at gender. Just as you can see, we didn't see a lot of disparities. Critical to any program that you're going to implement is that we look at any disparities. We want to look at inclusion and equity. And so while there were a lot more females screened than males, when you look at percent fail rates, there wasn't much disparity in terms of fail rates, fairly equal actually. We looked at the same thing by race, which I encourage, if you're not looking at race and ethnicity explicitly, you can miss things. So again, when we looked at I pulled out just the black and white, and then looked at, again, at fail rates. Again, we're not seeing a lot of disparities. So our initial findings are telling us that it's fairly equitable in meeting the needs of this community. So I wanted to get to follow-up results. So you see blue here on the screen. For each of the screening tools, we start with the assist, which is the substance use screener in the book, for those who had indicated opioid use, and then the PHQ-9. And what you see across the board is dramatic reductions in risk scores, specifically with the book, like a 64% reduction in PHQ-9, a very high reduction as well. Up until just a few weeks ago, the PHQ-9 was showing 100% reduction in depression at the 90-day follow-up. And then I want to just point, because the assist, it's harder to see the reductions in the follow-up results. And as Pam even alluded to, which again is part of the best practice of SBIRT, is that when a person comes in for that initial screening, there could be a couple things happening. First of all, they may not be fully truthful, right? So this is about self-disclosure. And so there may be some distrust with the system. And so they may not fully disclose their use. And so some parents may actually screen higher on a follow-up screening once they realize that, you know, the best thing for their child and to move forward in their case plan is to get the resources they need. In other cases, as I kind of indicated earlier, the parent may, their substance use disorder or may have been at a moderate risk, maybe even low, but due to the stress factors and maybe the substances being their best known coping mechanism, cause that those risk factors to elevate. But for the most part, we're seeing reductions. And here in this slide, we broke it down just by substance type. And you'll see really across the board that we're significantly reducing the high-risk population. So again, low, medium, high, initial screenings are green on the slide. Follow-up screenings are yellow or orange, depending on your screen. And you'll see overall, especially when you go to that far column of high risk, that there's great reductions and almost eliminated high risk in all of the substances except for opioids. And then again, here at opioids, your far right bottom of the screen, you'll see that nearly 10% were screening high risk initially, and less than 5%, about 2% are screening high risk at the follow-up.
And Phil, I just want to jump in. I think a lot of that might be as well with the follow-ups is in the initial screening, we saw that they were high risk, so we obviously referred them for treatment. So in 90 days, they've been able to maintain their sobriety, and because they've completed a treatment program as well, which we knew immediately after completing the screening that they were high risk. So we want to get them into treatment as soon as possible.
Absolutely. And so absolutely correct intervention is, and so that connected to timely treatment, as we talked about early on in the webinar, so critical for child welfare outcomes. And secondly, the quality, and then treatment completion is the robust outcome or indicator for successful outcomes in case closure and or reunification. So again, the well screen though product allows you to pull this type of data so you can see in real time and give feedback to your staff and to your administration on the impact you're having on children and families. So here are some initial findings, and we're going to now turn to a point of questions. So you can use the raise hand function if you'd like to ask a question live. We'd try to unmute your line. Again, I want to encourage you to use the Q&A function at the top of your screen or the chat function. Any of those, we want to try to engage you in the last couple of minutes that we have with you. But here's kind of a summary of the findings. 206 screens administered. Of those, 62 scored positive for your opioids. We pulled that data out specifically just because of the epidemic that we're living in right now. Of those, 52 or 84% scored moderate to high risk. So we didn't find any significant disparities by gender or ethnicity, and we saw large reductions in risk scores for the assist, for the 66% reduction on the PHQ-9, which is the depression screener. And you can imagine when a parent comes into the child welfare system and learns that they are going to lose their child due to neglect or parent or their substance use or alcohol use, and if they're fighting off, historical trauma or childhood trauma and or dealing with some depression, to have a 66 reduction on the depression screener just within 90 days is significant, especially since they're so early on in the child welfare case. And then a 60% reduction on the book, which means that here in Lafayette, they're greatly reducing the risk of opioid overdose, which means that we're reducing the risk that a child's going to be orphaned due to a parental opioid overdose. So that's pretty significant. And I think from what we're hearing from both Pam and Darcy is, and I've had a chance to meet with them every month since they've implemented this and looked at some qualitative data, and there's significant reductions in their workload in terms of case management and administrative, and their access to data and reporting and ability to apply for grants. So those are just some of our initial findings. I don't know if Pam or Darcy, Carolyn, any of you want to jump in at this point? It'd be great if we can all just join the panel.
I want to say one thing. I didn't mention this in mine, but regardless, obviously I have a lot of rapport with some of the facilities throughout the state of Louisiana, so they're kind of familiar with me making referrals. But even if they weren't familiar with you, a lot of facilities will require an ASI, and a lot of treatment centers or treatment providers aren't doing that anymore. I have had 100% success rate in referring a client using the data from the well screen. They've accepted it. They take it. And so if you're not able to have someone who can just get up an ASI up right away, this would be a way also to provide the treatment center with some form of assessment, letting them know that why you're making the referral.
Yeah, so critical. And that's what we talk about, that warm handoff. It's so critical in the child welfare system, is being able to provide the treatment facility for those, again, those high risk, maybe moderate risk families, background information on the case, so that the treatment facility knows, has some background information and can do a proper and quality clinical assessment at that point. So that's excellent. Thanks for sharing that, Pam. All right, let's go ahead and again, we're just gonna take a few minutes for some questions. If you'd like to ask a question, you can, again, use that raise hand function. I'm gonna turn on the participants on my screen so I can see if you're raising your hand. Should be able to do that if you click on participants at the bottom of the screen, which you can click at the top. So go to the top, you should see participants there, find yourself, and then there's a raise hand function. If you do that, it will flag you for us, and then we can unmute your line. You're also, of course, able to use the chat function. Okay, just looks like one question from the chat. So, and Pam or Darcy, either one of you can answer this question. So prior to WellScreen, what was the screening or assessment process you were using? I know, Pam, you had mentioned ASI. I'm not sure if that's what you were using. And then how long was that taking? And did you receive any specific training for that particular tool? And how is it different from what you're using now?
The first tool, when I came in 2013, the first tool we were using was the SASE. We were trained on the SASE, then we used the TCUs. The SASE didn't take long at all, but we found that we weren't getting great results from it with our parents. So we went to the TCU, which took quite a bit of time. And we found that the clients would come back to us, we had them, and they were answering it themselves. They would come back to us and said, I've never been in jail. I don't know how to answer this. This has never happened to me. There was a lot of information that was on the TCU that it didn't apply to them. So it only lasted about a year, and I just said, I can't do this anymore. The information is not correct, that it's not valid, it's not a valid tool for our population. Then actually somebody who's on the training, I reached out to her, Catherine Prejean, and I asked her, I said, do you know of any tools? And she helped me find the CAT5, which was a great tool. We liked it. I think we used it for probably 2.5 years. Pam could correct me if I'm wrong.
Yeah, it was about 2.5. Well, right before the well screen. So about
it was right before the well screen. It was a great tool. The problems we had with the biggest issue is it took a really long time.
And it used a lot of paper.
Yeah, it took about a year.
It was about 175 questions that you had to go through after having them, fill out the initial packet. So, I mean, you're looking at like an hour and a half. And if you have clients back to back, you don't have time to build rapport. I mean, you're just trying to get the packet completed. Mm-hmm. So that's when I went to Darcy and I was like, Darcy, something needs to be done different. It's 2019. There has to be some form of electronic system that we can use, that it can be kept onto the computer, put on the computer, but also not take as long. And so that's, as the case manager, that was the biggest, thing for me with the well screen, was that it is so quick. You can complete it within, 10 minutes. It just depends on how much you want to talk. I'm a talker, so it usually takes longer, but it just depends on how long you want to talk. So that's when we started using that. But the CAT5 was also a great tool. It just took a really long time, and it was only on paper.
It was a really great tool, but it just, and they did not have a computer-based tool that was out. So at that point, we decided we had to switch for Pam's sanity in mind. So.
Nice, yeah, and I can imagine too, an hour and a half, especially if there's children in tow, right? I can remember from my experience in managing family preservation courts and other child welfare programs, oftentimes the mother, most of the time it was, they had their children sitting out there, and and a mother of 2 children, having my children wait in the lobby for an hour and a half probably wouldn't end well for my kids.
No, it didn't.
Yeah.
I mean, we would have assessments last 4 hours because it would take that long to do the paperwork.
Yeah. There's okay, another quick question. I think this one more for Carrie Lynn, and this is specific, I think, to the WellScreen product. Carrie Lynn, if a community had a specific assessment or screening tool that they wanted to implement or embed into WellScreen or into this process, can you talk about how to customize this to fit another community?
Sure. So we can integrate any any tool into the system that a community has. It's easiest if that tool is in the public domain. So something that was like developed by a government agency like SAMHSA or the World Health Organization, that kind of thing, is easiest for us to use. If it is not in the public domain and it is has copyrights and other things, then we would have to negotiate with the developer of that tool to see if they would give us a license or some type of rights or access. The Craft is proprietary tool, but Boston Children's has given us the ability to use it and integrate it in our tools. And of course the book is proprietary, but we negotiated a license for that. So there definitely can add additional screeners, and then the workflow is completely customizable. So if you want to, as Pam mentioned, they're sending the screener now. There's a way to set it up so that the screener can be sent, they can be completed, and then but the results aren't presented to the particular parent. Those results are shown to in the system for Pam and Darcy to review before they actually have that conversation. You may want to do a different workflow as far as which screeners come in what order. All of that is customizable within the system for each account.
Great. And this is the last question we're going to have time for today, because I want to hold true to our timeline here. And Pam or Darcy and Carrie Lynn, maybe from other communities, but given where we're at with COVID and stay-at-home orders and increase in telemedicine, Pam, you kind of alluded to this in your presentation that you're able to email, but are there other kind of telemedicine platforms that you're using in which you're able to kind of continue to screen parents and implement the SBIRT model?
Well, we're doing everything through Zoom. So I'm able to, instead of having the client fill out the packet that I give them, the initial packet, which you can tailor to any of your programs. Ours is called the AIMS because that's the program, but you can tailor it to any program. It's exactly the questions. It's all the questions that are asked in information that's asked in the program that we just put onto a paper format that the clients can fill out. But I do everything either through FaceTime or Zoom. And I fill that out with them. And then I go to the WellScreen tool and complete the assist and the PHQ-9 or the book. But it's all done through Zoom. And one thing that I've learned, I think me and Phil have talked about it before, is I make sure to wear headphones. So I let them know that it is confidential, it's private. And something else that you want to make sure that you implement as well is a consent form. You need to let them know who you're going to be giving this to once you're completed. Whether it's a treatment center or the child welfare worker or the judge, whoever it may be, you need to make sure that you have a consent signed for them on the initial contact that way you have the opportunity to go ahead and send that to whoever you need to once it's done. And they're not blindsided. You sign the consent. But now I do it and I have a witness usually. And then that witness leaves and I complete the screening with them once we're done. But yes, we're doing everything through Zoom still right now.
Awesome.
All of our support group meetings are on Zoom. The parenting's on Zoom. Our treatment is on Zoom. Everything as right now is still.
Great. Well, thanks for sharing those wonderful tips and lessons. We appreciate both Pam and Darcy, your willingness to kind of share your data with the audience, as well as your early lessons learned. And again, as I talked to you throughout this process of implementation, some incredible results that we're seeing here that I hadn't seen nationally in multi-year initiatives. So excellent job. Again, thank you to all of you who have participated. Thank you to our panelists. Thanks to Carolyn Coleman. If you'd like to learn more, you can go to wellscreen.health and you can schedule an individual appointment there, or you're welcome to reach out to any of us. And I think with that, if there are no other comments from our panelists, I think that will conclude today's webinar. So thank you all very much for joining us today.
Thanks for participating.
Thank you.
Thank you.